Hello, this is Michael Altos recording the first in a series of lectures on the allergic response, which corresponds to Barish Chapter 12, and this is part 1 of the lecture series. First, we're going to take a few moments and review some principles of immunology. Let's start by remembering an antigen. An antigen is simply a molecule that stimulates an immune response, and antigens can be comprised of a number of different kinds of molecules. They can be polypeptides or macromolecules. The point is that antigens tend to be relatively large molecules. Examples include latex in the OR, some of the colloid volume expanders that we use, neuromuscular blocking agents. All of these are common antigens. Now, most drugs that we give are relatively small molecules and actually aren't large enough to be a complete antigen. And so we use the term a hapten. A hapten is a small substance which binds to a larger molecule and creates an antigen. So a good example would be an antibiotic, which is a relatively small organic molecule. And the antibiotic binds to a larger molecule, and that creates the antigen, which creates the allergic response. Next, we're going to talk for just a moment about different kinds of immunity. And the first kind of immunity is cell-mediated immunity. The idea here is that certain cells are tasked with the job of eliminating or destroying pathogens or other foreign cells. And those cells might include lymphocytes, and as we know, there are T cells, which influence and implement the immune response, as well as B cells, which differentiate into plasma cells and ultimately synthesize antibodies. And then antibodies themselves are immunoglobulins. They are molecules that can recognize or bind to a specific antigen. They come in 5 different flavors, the IgGs, M, E, A, and D varieties. And when an antigen binds to an immunoglobulin, this causes an activation of the immune response, leading to proliferation of lymphocytes, secretion of additional antibodies, and then mast cells start to degranulate the various substances that are located inside of them. Additionally, the complement system can be activated in response to activation of an immunoglobulin. There are many effector cells in the immune system. There are monocytes and macrophages, which are responsible for ingesting and processing antigens and then presenting them to the immune system. There are neutrophils, which secrete proteases and lysozymes and radicals, and they are cells that are involved in microbial killing. Eosinophils, which are commonly involved in parasitic and allergic reactions. Mast cells, which we typically find in the perivascular spaces of skin and lung and intestine. These mostly contain IgE receptors and are involved in the hypersensitivity responses, as we will see later on. And then basophils, which are in many ways similar to mast cells and are also involved in IgE-mediated immune responses. And we'll discuss those more in a few slides. In addition to the cell-mediated immunity, there's also humoral immunity. And this involves antibodies and complement proteins and cytokines and other various signaling molecules like chemokines and interleukins. And this humoral immune response is involved in orchestrating the cell injury and the destruction. The idea being that if bacteria can be recognized, then other cells can be attracted to the site of these bacteria in order to promote a destruction of bacteria through the immune response. Now, in addition to cellular versus humoral immunity, some people like to divide the immune system into innate versus adaptive immunity, where innate is sort of your rapid response team. It's the no specific memory system that just responds to anything that seems to be foreign, whereas the adaptive immunity has a little bit more of a delayed time course, but involves antibodies that have specific memory of prior exposures. Pause here for just a moment to see if you have any questions, and you're certainly welcome to contact me ahead of time or bring those questions to class. Moving on now, the first thing I'd like to talk about for just a moment is angioedema. I've spent a lot of time thinking about angioedema and how to understand it and classify it, and I've culled a lot of material from different sources, and I think this is a pretty good description of angioedema in general and in a number of specific circumstances. So angioedema's definition is any swelling of the deep dermis or subcutaneous or submucosal tissue, typically due to vascular leakage. We commonly see angioedema in the lips or the eyes or the face, but it can also occur in hands or feet. It can actually occur in the GI tract as well, or in respiratory mucosa. And if there is angioedema of the larynx or the tongue, it can actually be life-threatening. Here are just some pictures for you of angioedema of the tongue. And we do see this a lot more commonly than most people realize. It can be due to ACE inhibitors, but it can be due to other precipitators of the immune response as well. Here are some pictures of angioedema of other parts of the body. Here we see angioedema of the uvula. Over here we see remarkable one-sided angioedema of the face involving the lip, the nose, and the eyelid, as well as the cheek. Here's angioedema of the lip, and here is some angioedema of the hand. Now, there are several different etiologies for angioedema, and they are all quite different. First, there are patients who have hereditary angioedema, and this is always due to a C1 esterase inhibitor deficiency. This is part of the complement system. Other patients have, instead of hereditary, they have acquired angioedema. This is pretty rare, and this is due to some sort of a process that consumes the C1 esterase inhibitor, so they're not deficient in synthesis of this inhibitor, but rather it gets consumed. And immunologists like to break down the acquired angioedemas into two types. Type 1, which is sometimes involved with a B-cell lymphoproliferative disorder, or angioedema type 2, which is an autoantibody that attacks the C1 esterase inhibitor. Again, these are all pretty rare. Then we have the histamine-mediated angioedema, and this is what we think about in patients who have anaphylactic reactions and they get swelling in their airway. And finally, there's ACE inhibitor-associated angioedema, which seems to be an entirely different phenomenon in and of itself, and we're going to discuss that a little bit more in the upcoming slides. So what triggers angioedema? Well, in patients who are susceptible to angioedema due to some underlying pathology, angioedema can be triggered by a number of different stresses, including menses, trauma, infection, just taking oral contraceptive pills. Patients who have hereditary angioedema may have their angioedema precipitated by any trauma to their airway, which could include dental work or even suctioning, and certainly placement of an endotracheal tube or an LMA. But in patients who are predisposed to angioedema, we can't say that there are any specific anesthetic drugs that are contraindicated. Let's talk for just a moment about the ACE inhibitor-associated angioedema, because there's a lot of misconception about this phenomenon. ACE inhibitors are actually a leading cause of drug-induced angioedema, and about 20 to 40% of patients who present to the ED with angioedema have ACE inhibitor-induced angioedema. An intensivist at Richmond told me he sees about 1 case per month in his ICU. Usually the angioedema occurs in the first 3 days after exposure, but patients who have been taking ACE inhibitors for years, and certainly even within weeks, have experienced an unexpected episode of angioedema precipitated by the ACE inhibitor. The mechanism seems to be due to bradykinin, and these patients have elevated levels of bradykinin. Remember that bradykinin is normally inactivated by ACE, by angiotensin-converting enzyme. And so these ACE inhibitors may cause elevated levels of bradykinin, leading ultimately to vasodilation, plasma extravasation, and the phenomenon we see as swelling due to angioedema. We do see it more in patients of African descent, as well as patients who've had transplants, and certainly those who have a known history of hereditary or acquired angioedema. Typically, the angioedema resolves on its own within about 72 hours, but certainly supportive care is required during that time. Now, angioedema can be prevented with prophylactic treatment of patients who are known to have angioedema. So there are androgens, specifically danazol, which can be given to patients who have hereditary angioedema. And just as a specific pearl, this should not be given to patients who have angioedema type 2. Antifibrinolytics like tranexamic acid or Amicar have been used also as prophylactic treatment of patients with known angioedema. Most commonly, people are aware of purified C1-INH, which is the C1 esterase inhibitor, and these go by the brand names of Cinryze or Berinert. And the most available treatment is usually just FFP. 2 units of FFP prior to airway manipulation may provide enough of the C1 esterase inhibitor to avoid precipitation of an acute episode of angioedema. Now, all of these are for prevention. What should we do with patients who present to the emergency room or to the ICU or to our operating room with an acute episode of angioedema? Well, the best treatment is purified C1 esterase inhibitor. This will treat all angioedema, but the problem is it may not be quickly available, especially if it is in shortage or if you're working at a small hospital. There are other drugs out there that have been studied. For example, kallikrein inhibitors, bradykinin receptor antagonists, and these may also be effective, but we're still faced with the same problem of availability. Now, a lot of people think that they see airway swelling and they're going to give antihistamines and epinephrine. And it turns out that a lot of these patients will have absolutely no response to those treatments. The exception, of course, being patients who have the classic histamine-mediated angioedema. Someone who's allergic to penicillin or bee stings and their airway swells up. Those patients may actually respond to histamine, antihistamines or catecholamines. But the ACE inhibitor patients and many others will not respond. Now, that's not to say it won't hurt to try, but your therapies may need to be focused towards other goals as well. Just a little side note that I learned, 15% of your H2 receptors are in the skin. So there's a lot of debate when we talk later about anaphylaxis and should we give H2 blockers. But in patients who have angioedema, it may be reasonable to give that H2 blocker just to minimize the cutaneous swelling that we see in the skin and other cutaneous tissues. Probably the most available, easiest treatment is a couple units of FFP. FFP contains the C1 esterase inhibitor, and so it may help treat the angioedema. There are some caveats. First of all, patients who have hereditary angioedema may see a paradoxic exacerbation, and that's because while you're giving the FFP, it also contains complement, and it increases the complement levels, which may worsen their syndrome. But for the ACE inhibitor-associated angioedema, it is a very good therapy because it provides kinase 2, which is also known as angioconverting enzyme, which is exactly the problem in the first place. And so that is a very reliable therapy and probably your first-line treatment for acute angioedema. Airway protection is key in these patients, whether it's by tracheal intubation or tracheotomy. But you should just remember that if the angioedema is severe enough lower in the airway, like in the trachea, a tracheotomy may be insufficient, and they may have swelling distal to your tracheotomy placement. That's it for this first recording. We'll stop here. Let me know if you have any questions, and we'll pick up with the next lecture.